right. So, hello, everyone, and welcome to another episode of the Scholarly Chronicles. We are still working out the name, but we will keep going with that for now. Today's podcast is about another very interesting doctorate completion project, completed again through Middle Tennessee School of Anesthesia. I'm Hallie Evans, here with my co-host, Jordan Billings. And we would just like the participants to tell us a little bit about themselves. They're all doctorate students and also in our Payne Fellowship. So this is an interesting bunch. So go ahead.
So Dr. Evans, I've been asked to introduce our team members myself because they don't want to talk. So, is that okay?
Podcast. Okay.
All right. So I'm Tom Aminetti. I'm 1/3 of the team here on the effectiveness of transversus abdominis plane block training toolkit for post-surgical pain management following cesarean delivery, a quasi-experimental study. My team members are Kimberly Brantones, who graduated from the University of Pittsburgh Anesthesia program in 2004 and has spent most of her career at a Level 1 Trauma Center in Pennsylvania. In January of 2023, she proudly completed the Acute Pain Fellowship at MTSA. Kimberly is a proud mother of 2 who loves to travel and spend time with her family. She also enjoys giving back to less fortunate people by participating in medical mission trips to third world countries where she provided anesthesia and nerve blocks for surgical procedures. She has completed 3 mission trips to Honduras and will then visit the Dominican Republic in November of this year. Our other team member is Lynn Sherrill. He graduated from MTSA in 1999. Lynn, interestingly enough, led an all-CRNA group at a hospital in Shelbyville, Tennessee for 21 years and taught regional anesthesia at MTSA in the classroom and clinically from 2001 to 2010. Lynn works with me at the Williamson Medical Center in Franklin, Tennessee, where we both do OB, plastics, and he does some endoscopy anesthesia at a surgery center. And he, too, will complete the Acute Surgical Pain Fellowship at MTSA in August of this year. I've been a CRNA for 26 years. I'm married and the proud father of 4 daughters. That's where I get all this gray hair from. Before starting my anesthesia career, I served 12 years in the service, military experience, Marine Corps and Navy. I enjoy hiking, scuba diving, and spending quality time with my family in my free time. My biggest passion in anesthesia is driven by doing regional anesthesia. That's how I ended up here. It's a long story, but I love eliminating pain. This whole project, I think, has been rewarding for all of us, but I will finish the Acute Surgical Pain Fellowship and this year as well. So that's our team.
Wow. Well, after those introductions, I think I can honestly say it's quite an honor to have you all here and hear about your project and the process just in general. I know a lot of people find it helpful, and you after all this hard work, you deserve to tell a little bit about how you did it. So let's go ahead and start with the type of project you completed and the model you followed. Tom, do you want to tell us a little bit about that?
Yeah, so we did a quasi-experimental study. It was guided by the Johns Hopkins evidence-based practice model. As you know, it's a framework that translates research into clinical practice, ensuring the highest standards that we can, possibly follow. We conducted a comprehensive literature review using all the keywords like cesarean section, nerve block, transverse abdominis plane block. We used PubMed, Cochrane Library, and CINAHL, and we were guided by a Prisma. And we tried to be as thorough and meticulous as we could be. And these are Lynn's words, but we tried to leave no stone uncovered. So that's how we went about it.
I like that, no stone uncovered. That is a thorough search strategy for sure. I like to talk about how we take away the step of forming the team. What's kind of unique about your team is that 2 of you already knew each other. and you had already kind of gotten to know Kim, and that you would work well. And you guys, speaking from the instructor side of all this, were like the utopia of a team. So maybe we could just pause on that step for a second and just talk about why you think you work so well together.
Kimberly, you want to answer that? Because we discussed that today. Or I can. It's okay. It's kind of ironic because Lynn and Kimberly worked together on a previous project prior to us coming together for this project, so they knew that they worked well together. And I asked her today specifically. I said, "So remind me, how did you come about this? Getting in with us?" And if we got back to you guys, our Lynn and she had worked together, and then we just have common interests. We all do OB, and it's kind of our passion to work in that corner of the world and maybe make things better for our OB patients.
I'm always, I shouldn't say surprised, but I still am a little surprised when teams can't work out issues, because we're nurse anesthetists and we work with difficult personalities in the operating room. It's something as nurses, even before we were CRNAs, we probably have dealt, with different strong personalities. And so it just makes me re-energized and have faith when I see a team work so well together. So I really appreciate you guys for that. I know you talked about your search strategy. I just want to ask, was there anything else that really helped you, leave no stone unturned? Like, did you reach out to any librarians or library resource personnel that helped with the search?
Yeah, actually, we did. We used the librarian at Middle Tennessee a lot. Lynn and I actually went to the school and sat down with her, and we went through this from the beginning until the end. And it's funny that you asked that question because I actually emailed her a few days ago to thank her for all of her help. So
thank you, Sharon.
Sharon was great. Exactly.
She's a gem. Shout out to Sharon Harmon. We'll make sure she watches this.
So we're going to talk a little bit about the project design in general. Kim, do you want to speak to that a little bit and tell us what you decided to do with the information you all gleaned from your search strategy that you found, and how did you come to this decision?
Actually, I've got that one. So,
okay.
As Tom said, our project was designed as a quasi-experimental pre-test, post-test study to evaluate the effectiveness of a TAP block training toolkit for anesthesia providers that we put together. And we chose this design to measure changes in knowledge and confidence and the willingness to implement TAP blocks before and after the educational intervention. And so the pretest assessed baseline knowledge and confidence levels, and then we had a follow-up comprehensive training toolkit that was narrated with a PowerPoint presentation. And then after 4 weeks, we sent out a post-test to gauge the impact of the training of the training toolkit. And it was designed to clearly see if there were any improvements and identify areas needing further enhancement. And I think we kind of decided that we wish we'd sent it out maybe after 2 weeks instead of 4 weeks. We might have gotten some better responses or maybe some better memory of what they learned. So, but we are doing this CRNA. So
yeah. That's good to hear. That's good feedback too for future surveys. Did you, besides the obstacles with when you sent out the survey, did you guys just encounter any resistance at work from people not interested or not wanting to participate? Was that a problem for you?
We just, Tom and I had to kind of sell it a little bit. There were QR codes posted in different areas, and we just kind of had to drive people a little bit. Hey, have you done your survey? We'd like for you to participate in this project. And so we had to coax a little bit, but we had pretty good participation. We wish that we had that people were able to follow directions a little better. That probably would have been helpful.
And I know you guys used Lewin's change model, and you did an impact analysis and a data analysis. Do you guys want to talk a little bit about that and how you coordinated the team?
So
the data. I'm sorry. Go ahead.
Well, the team coordination is we all had specific things, and I've tried to keep us informed about timelines and potential constraints, and tried to ensure everybody was on the same page. We all attended every synchronous group meeting, and just all of us are very good communicating with each other. Tom did a great job of making sure that putting our submissions together and getting the submission together, and Kimberly's a wonderful writer and editor of things. So it just was a great team, and none of us like to be late. We always, all of us are like to stay ahead of schedule, which drives all of us. So
If every group could be like you guys, it would.
Oh, right. It's like
Yeah.
a dream group here.
Get along. You like
Wow.
to be early. Anything else?
Goodness. So in this process with all of this, did you need to survey participants? And if so, what ethical considerations or consent did you provide for the survey?
You want me to tackle that one?
So we, to recruit participants, we sent out a personalized email invitation to all the anesthesiologists and CRNAs at the hospital where Tom and I work, and the emails included detailed information about the project and emphasized the importance of the study and the benefits of participating. And attached to those emails were secure, QR codes, links, and things to consent forms that ensured confidentiality and voluntary participation. And once the participants provided their consent, they were given access to the training toolkit. And after they completed a pretest to assess their initial knowledge and confidence levels, they reviewed the PowerPoint presentation, which was narrated. And after 4 weeks, they completed a post-test to measure the impact of training. And this type of structure ensured that we gathered comprehensive data while respecting participants' privacy and time. And Tom and I, they had the link to the PowerPoint presentation, and then Tom and I also presented it live at the hospital for continuing education to the same group. So they were able to get it more than once if they really wanted to.
And then did you guys have to go through any ethical training? Did you do city training and go through a ethical review committee for this project?
We did.
And how was that process? Pretty smooth? For you
Yeah,
guys?
we all did city training. All of us did city training, and we did submitted our ethical review to the committee at the school.
Surveys are always interesting. Some of the stuff we expect to see, and some of the stuff just pops up that we didn't expect. Can you guys kind of tell me what you expected and any findings that you found surprising to you?
Well, if I could interject just for a second. So one of the things that I expected a lot better participation from our group than what we got. I mean, there's 24 CRNAs there and 8 docs. And when we held our live educational meeting, we only had 2 docs there. And not even all the CRNAs were there. And I fully expected the CRNAs to fully participate just because they're our colleagues, and they did not. So, that was surprising to me. Sorry, I didn't mean to interject there, Lynn, but that was one of the things that really stood out as far as I was concerned.
And
How many CRNAs did participate?
We had 21, I think, out of that.
Oh, okay.
So it ended up being a decent amount at the end of the CRNAs. I think this is worth,
we had to really
yeah,
push for that though,
exploring.
because that's
Yeah.
not what we had in the beginning. We had to, keep reminding them, we've got this available to you. Have you done this? Well, I haven't. I just haven't had time, or there were lots of
Yeah.
reasons that were given, but we kept pushing within those 4 weeks, and we finally were able to get 21 out of 24.
Sometimes those are studies upon themselves is like the reasons why people wouldn't complete
Right.
your survey. I think it's worth like just talking about this for a minute, and I'm not a political person. Do you think there was any resistance from docs because it was a CRNA initiative, or you think people just had other reasons?
I think
To not
Lynn and I
want
would both agree that yes, because this was driven by the two of us at our facility, we met much resistance from the anesthesiologists because not
This
all of
is a
them know how to
culture
do that
change.
blocks.
Major
Yeah,
culture
it's
change.
it's a major culture issue, and they don't like change. We found that maybe there might be a little bit of laziness on their part, and but since all this has transpired, we've had some of them come to us and say, okay, can you teach me how to do this? I've not, been able to do this, and I'd like to learn. And as you know, Dr. Evans, we kind of put the cart before the horse. We approached administration about buying an ultrasound machine, which they spent $60,000 for, and they, expected us to start doing these blocks. And so we did start doing them, and we have gotten some great feedback after doing these blocks over the last year or so.
That
And
makes me
the
so
other side
happy
of
to
that-
hear.
That's amazing.
And the other side of that too is after Tom and I being very heavily proctored during the process, now they don't look at it as any differently than us just doing an epidural, and
great.
it's
Mhm.
it's just go ahead, it's good, which is
And
great.
I mean,
for autonomy.
that is the goal of this project, for you to become an expert on this topic, and since yours was a skill and hands-on, I think you could tell us not only everything about it in the research, but know how to do it to an expert level as well, so you've really fulfilled the goals of what this project is about. I want to go back just for a second to the recruitment. What did you guys do to recruit? I know that you pestered people after the fact when they weren't doing it, but what did you do to try to initially get them to be part of this?
We sent an email out to the whole anesthesia staff, basically stating, this is what we're doing. This is what we'd like for you to do if you're willing to do it. And we sent that out more than once prior to an education meeting. So they knew what was coming. And our education coordinator actually coordinated with us to say, hey, can you guys do this on such and such date? And, we were like, no, we can't do it then, but we were able to do it. I think we did it, was it March or April that we did that, Lynn? It was on the 10th of April, wasn't it?
Yeah.
But anyway, we kind of lined that up with our education meeting because that kind of forced people to have to be there. And so that helped, and so it was an hour-long session that we actually, took 45 to 50 minutes to do, and then we opened it up to questions after the fact to try to, give them an opportunity to ask questions of what might be coming. We didn't want to skew our results, but, we did give them an opportunity to just, ask questions about what they just saw. So.
And you mentioned Kimberly was a excellent writer, and I have to say she's an amazing student from the very first course. So we have to hear her voice during this podcast.
Yeah.
So I want to know, Kimberly, if any of the results surprised you or just anything that you found interesting.
Well, I was really surprised that we didn't get statistically significant results. I fully expected better participation from the CRNAs and us to get statistically significant results. But even though we didn't get statistically significant results, we did get some positive results.
And we talk about statistical significance versus clinical relevance, right? So now that this part is done properly, it'd be really interesting to see, decreased studies on decreased opioid requirements or other pain medications after, so while this, small kind of pilot study may not have seen statistical significance, I think the clinical impact is going to be huge, right? We already know that it is. So I think really don't get bogged down with that.
Absolutely.
You guys are making a huge difference.
I think so too. I just want to say it's encouraging, even as a fellow CRNA, to hear what you guys have done, because we talk about nurse educators being change agents and all that kind of thing. And honestly, all CRNAs can be change agents. And I've worked somewhere, and I think maybe we've all worked somewhere where we know they need a culture change, and it feels impossible as like one person to do that, let alone two or three. But the fact that you guys, all it takes is kind of getting your foot in the door, just one tiny little wedge in there. And it just kind of, you guys have shown how effective you can be if you're like persistent and do it the right way. And so I think that's very motivating for me and maybe other CRNAs or students that might listen to this podcast in the future to not give up with their project or think that it's impossible, just to know that these actions can really make a huge difference, because I think people innately are resistant to change. Not only CRNAs and docs, I think everybody is, but we all get set in our ways, especially at work. We're like, no, this is how it's done. So the fact that you guys could kind of break into that is a pretty big deal. So did we want to talk about the feedback a little bit? Yeah, okay. So the surveys that you did send out, based on the feedback that you did get, did you need to change anything about your project or make any conclusions from what they said?
Yeah, well, what we found was they really had a high interest in learning, but they did meet a lot of barriers, and they reported that the most significant barriers were surgeon buy-in, time constraints, and resistance from the anesthesiologists to allow them to get the hands-on experience that they needed to increase their confidence and then reinforce the knowledge level of the material that we provided them. So I think a change in the future would probably be to try to maybe change the culture or reduce some barriers prior to trying to implement a training toolkit.
In your own personal experience, do you think the barrier of a surgeon buy-in is valid? Did you experience that yourself, going through this?
For sure.
Yeah. I'd say, and in my, place of employment, in Pennsylvania, it's always an issue. So yeah, I think it's very
right.
I think that brings up a great point, because sometimes these projects, or the point of these projects really, is to spawn other projects. So yes, we could go on and study now tap blocks and narcotic usage in this patient population or skill level with anesthesia providers, but we could also take a step back, right? And say, hey, before you do this, let's do some education with surgeons and stakeholders so that we have already crossed that hurdle when we go to teach this. So, it's just, you never know what's going to come up. And there's just so much to learn from these projects. And, each project could produce 100 other projects by the time you look into details. And that's probably why my favorite section to read of any paper is the recommendations for future research, right? Because it's like, okay, well, what did you find that still needs to be found out? And that's kind of how we are. What more do we need to know, So, Lynn, what would you say is your biggest takeaway from the project?
People need to learn to read directions clearly. Just kidding.
I agree.
Good luck with that.
People that have been out 20 years plus are very resistant to change and are not interested in change.
That is very true.
But that's not really a surprise, I guess. But probably, for the future direction, is that what you want to know, or what other surprises?
Yeah, let's talk about that too. Yeah, where do you see it going from here?
Well, Tom and I are continuing to try to support the culture of implementing CRNAs do blocks and we're pursuing that now. We're just kind of getting that started, and we just think just a good perk for a job, for a CRNA at our hospital is maybe you can't do all the blocks all day long, but if you could just do your first block for your first case, if you got there early and you were interested in doing that, and I mean, not just tap blocks, I'm talking about, blocks for total knees, shoulders, and just what a great perk and satisfying way to just give a little something to CRNAs to say, hey, a little job satisfaction. So, and I'm sure that will be met with some resistance, but.
Yeah. And that comes up a lot is job satisfaction, just practicing to your full scope, right? We want to be able to do what we're trained to do. Any other takeaways anyone else wants to add before we wrap up here?
Well, maybe just this one thing. If we were to redo this project, we might do a little more ultrasound training with it, because that's what we found to be one of the biggest hiccups with this whole thing was, some people graduated well before 2015 and they don't have the experience using ultrasound. And so some of the basics, that the three of us just take for granted at this point, they don't. And so that was probably a little bit of a frustration, at least as we bring people up to do these tap blocks. You're like, you got to keep the needle on view, or you might tilt it this way, or, just the things that we do, without thinking about now, which we weren't able to do in the beginning, but they're just kind of starting out. So we might try to touch upon that a little bit more. I think that's probably one of the things that we've, came to a conclusion on with this. So
yeah, I think that's a really good point as well, because if you think about people, especially CRNAs, resistant to change, maybe there's some fear behind that of like, I don't know how to use the ultrasound, but they don't want to come out and say it. They don't want, if they've been a CRNA forever, they don't want to be embarrassed or anything like that. So I think that would be a good thing to do.
There's no replacement for hands-on training, for sure.
Yeah.
And now that the school has all these opportunities for hands-on learning and training with the cadaver lab at the school, that is an invaluable resource to really get some hands-on training and needling experience.
Yeah. And I don't know if everyone listening to our podcast knows that, but MTSA now has their own cadaver lab that will be part of simulation and workshops. We've always hosted workshops, but you've had to do them right outside the campus. Now we actually have that on campus. So it is an amazing asset of the school. When you think of the big picture of these projects, right, you're just one little piece. So there's all these projects that we can do if we're making like this whole kit, right, before your project. Now we know we can do something for buy-in, we can do some more ultrasound training, and there's probably even 10 other things, nurse manager staff to, get them to not yell at you that you're holding up their, whatever it is. And then on the other end, there's all these things we can do with patient satisfaction. So you guys have contributed to what can be like a huge template, for a project on a huge scale. And what you guys did is, amazing in the year that you have to complete these projects. I also just want to say, each project, we use Sharon Harmon from our Learning Resource Center, and we also have content experts. And you guys had Dr. Hogue from the Acute Surgical Pain Fellowship. She's our assistant director, and she was an amazing chair and guided you through this project, I think, with her expertise. So I do want to just thank her very much also. And thank you, each of you, honestly, for your amazing work. It's so exciting. We were more involved in the beginning, and now to hear you speak and everything you've accomplished, I hope you guys are proud. I'm really proud of this project.
Oh, am I? Thank you guys so much.
Yeah, thank you. I just want to add one quick thing for the content advisor. Dr. Hogue was invaluable as far as I'm concerned. I mean, she was incredible. So
I think you're getting red, Tom. Please go.
She helped me more than you could possibly
Yeah.
know. So
No, I know. She is
Yeah.
wonderful. All right. So we will wrap it up. We'll hope you'll join us on the next episode of Scholarly Chronicles here, right, Dr. Billings?
That's right.
thank you so
right.
much.
See you
Thank you.
soon.
All right.